All right, moving into rabies. Anybody seen a case of rabies in the last week or two? Anybody in a career? Not yet. No, and we probably won't based on the number that are out there. But if we approach these cases properly of those who may be exposed, we should never see another case. Anybody do any overseas work, Asia, Africa, anywhere like that? There are more cases over there. Did you know somebody who saw a case of rabies? You may have. All right, you did.
A friend of mine saw a case, they only diagnosed it with a hydrophobia. And the nurses pointed out that the patient was afraid of the jug of water by the bed.
Really interesting.
For 3 days with confusion.
And the outcome?
He died.
Yeah, I had a feeling they did. Pretty universal fatality there once they develop neurologic symptoms. But what is basically rabies? RNA virus. It's present in the saliva of infected animals and attacks the CNS following the peripheral nerves back to the brain. And that's why you get kind of constitutional symptoms first, and then you ultimately develop the significant neurologic symptoms. You ultimately get an encephalitis and or a myelitis. Initially, malaise, headache, fever, irritability. Imagine seeing somebody in cold and flu season with these symptoms. Are you ever going to pick them out? Probably not. And it's kind of like anthrax. Once you've decided that's what they have, it's too late. Once they've identified symptoms that are specific for that disease, it's too late. You're not going to be able to do anything to help them. You know, they get the hydrophobia, as you mentioned, where they have difficulty swallowing. They show panic when they're given any water or anything to swallow. Problems with chewing. Lots of different issues that way. And we'll talk about some of the symptoms also. So how common is rabies in the United States? Not very common. But worldwide, about 55,000 deaths a year are attributed to this, most likely in Asia and Africa, as I mentioned. In the U.S., 1 to 2 fatalities per year. So it's still out there, but it's very rare. And so the chances of any of us seeing a case of this in the course of our lifetime, in the course of our career, is pretty small. But we certainly don't want to be the one who could have prevented it, and we did not. Take a look at places where it just doesn't happen. Hawaii, what a great place to be. And I think that's why, one of the reasons why you have to fill out so many declarations documents when you're traveling internationally. They don't want rabies on their islands. They don't want rabies in Japan, Australia, Germany, the UK. It's just not there. So you want to make sure those places don't develop it. Norway and Sweden are also noted not to have any rabies cases. All right, let's look at abstract number 1. Epidemiology of human rabies in the United States, 1980 to 96. They investigated the cases that they were aware of. 32 fatalities. 11 cases were exposure in a foreign country, so not a surprise there. Interestingly enough, 25 out of the 32 cases had no definite animal exposure. Dog bite in foreign countries accounted for 6 of these cases. 1 bite in the U.S. Was from a bat bite. And then out of the 25 that were unidentified, they were able to take a look at the virus variants from analysis to determine what animal species it came from. 16 of them were from a bat. 8 from a dog and 1 from a skunk. If you could get close enough to a skunk to get bitten by one, that's probably Darwin working for all of us. It shouldn't get close to those guys. The bats, though, are the concerning thing. All right, and none of these cases received a complete post-exposure prophylaxis. None of them. So if they were identified as possibly at risk, the healthcare provider that saw them didn't serve them well. Incubation period on these particular cases, 53 to 150 days. And some of these cases, a good number of them, I think it was 12, were identified on postmortem examination only. So even after these symptoms developed and they died, nobody knew what was going on with them until the pathologist got a hold of them. And that's never the consultant you want to make the diagnosis, particularly if a patient you saw. All right, number 2. They were reported here in Annals of Emergency Medicine 1983 that the incubation period could be as long as 1 year. So it makes it that much more difficult to attribute this to a bite or an exposure. Prodromal symptoms, 2 to 14 days. Then you develop the neurologic phase for 2 to 7 days, and after that you're going to succumb to the disease. And they identified all the symptoms you'd experience with the neurologic phase. Difficulty biting, chewing, swallowing, hydrophobia. They may have manic behavior kind of intermittently with lethargy. And then they get this certainly salivation they can have with it also. The final stage, coma, respiratory failure, cardiovascular collapse, and then death. So not a great disease. You know, I think about those symptoms. You guys like movies? And I'm thinking about like I Am Legend. Wasn't that pretty much the rabies virus that all these people got? And then also Dawn of the Dead, the mall scenes. Well, that's pretty bad. But I think that's pretty much rabies in humans also, but a little bit exaggerated. All right, there were really no human-to-human transmissions. But if you look at one case they found, It was from a corneal transplant. So from normal mechanisms, it really wouldn't happen, but one was from a corneal transplant. They did note, just so you're aware, that 5% of vaccinations in domestic animals fail. So sometimes it just doesn't work out, so there's a little risk there. 40 to 50% of people who actually get exposed to a rabid animal with a bite won't develop the disease anyway. But those odds aren't very great. Now, let's not prophylax you. You got a 50-50 shot of developing rabies anyway. It's not great, so you certainly want to provide the prophylaxis. And how do we diagnose it? If we think it's there, we can use rabies antigen, antibody, or you can look for the viral complexes. All right, which animals carry rabies? That's a tricky question. Two different questions there. Which ones carry it and which ones are actually going to be vectors for it are two different things. I mean, rabies can infect most mammals, but not every mammal is going to infect another mammal or infect a human. It's carried and spread by wild carnivores usually. Look at, interesting, in between 2000 and 2006 in the US, more cases of rabies were reported by cats than dogs because of all of the legislation and local efforts to make sure that dogs aren't running wild and immunizations are taken care of. Really, cats in the US are a bigger issue. Worldwide, particularly in India, dogs are a bigger issue and a primary vector there. All 4 human cases in the US between 2005 and 2006 were caused by what vector? The bat. And that's a scary thing. Anybody like bats? Oh, I tell you, scary stuff. That would not be my primary concern when I saw a bat. It would not be rabies, but it would be one of them, but it would be after the fact. All right, abstract number 3, suggestions for determining treatment following human exposure. And they looked at 35,000, they said 35,000 were immunized annually, so looked at all of these cases, 116 patients. They said with immunization, 100% of them had local reactions, a third of them developed constitutional symptoms. So it's not that these immunizations are going to be benign, but certainly if you're exposed, you don't want to take any risk of getting rabies. The circumstances of the exposure really need to be documented. Is it provoked or unprovoked? What's the vaccination history of the animal if you have that? Wound care is very important, and sometimes we'll talk about in some of the abstracts, it's been omitted. Rabies immunoglobulin should be in and around the wound, and then you want to provide your immunization, the vaccine, right in the deltoid. They specifically want it in the deltoid. They recommend also delayed suturing of a wound if you think rabies is probable. They want you to leave it open for delayed closure. And again, rabies vaccine is important. The immunoglobulin should be given within 24 hours. Okay, so who should get vaccinated? Well, some people need pre-exposure vaccination. If you're, handling a lot of animals, you work in a zoo or whatever, and you talk about the spelunkers. Everybody know what a spelunker is? Cave dwellers. Anybody here a cave dweller? You like hanging out in caves? Nope? Okay. I guess it would be kind of fun. I mean, it would have been kind of fun until you realize this bat thing. If there was any remote interest at all exploring caves in the back of my mind, it is done. It's over. As soon as you start hearing those wings flapping and those little screechy sounds, man, I'm out of there. I don't need to see any of the stalactites or anything else that's in there. It's just not that interesting. So I'm out. But those people may need to have pre-exposure prophylaxis. And then for post-exposure prophylaxis, very important to make sure that we again review the important pieces of information to see if somebody needs this or not. What type of animal was it? Whether the animal was wild or domestic? What was the immunization status of that animal? What was the behavior of the animal? Again, was it provoked or unprovoked? Was it very unusual? What did the animal look like? Whether the animal is available for observation. If you can observe the animal, maybe you don't have to jump into post-exposure prophylaxis. And the state or country where the exposure occurred. We know if it's Asia or Africa, we're pretty concerned. If it's Hawaii again, it's Sweden, don't worry about it. I'm sorry you got bitten by something, but you don't have to worry about rabies there. All right, abstract number 4. Post-exposure rabies prophylaxis in an urban emergency department, Journal of Emergency Medicine, 1996. They've said that basically very little had changed in 20 to 30 years, but what also hasn't changed is our inability to really follow these very simple guidelines. They looked at only 63 patients with an animal scratch or bite. Animal vaccination status was only documented 58% of the time. Behavior of the animal, 46% of the time. Wound care either wasn't performed or it wasn't documented. It was only there 34% of the time. And post-exposure prophylaxis, inappropriately not given in one case. So when somebody really needed it in these 63 cases, they didn't do it. So I don't know if that speaks in general to how emergency physicians and emergency departments are approaching this, but I assume it may. And it does shine an extra light on how we're doing things, and when we do have exposures, we need to make sure we take a look at them critically. And ultimately what they said was, here is the treatment recommendation. Wound care, irrigation with soap and water. If you want to use some betadine, that's fine. Give the immunoglobulin 20 international units per kilo. Give half in and around the wound. If it's convenient, some areas you just can't do that in. And then the other portion, the other 50%, you give in the gluteal area. And then you give your HDCV, and you're going to give that 0, 3, 7, 14, and 28 days, 1 cc. And then you're set, and you've taken care of them. That should be given in the deltoid. Again, they specifically state that they don't want it in the gluteal area, they want it in the deltoid. Abstract number 5, rabies post-exposure prophylaxis, basically emphasizes the treatment recommendations we just talked about, and also they reviewed failures. And in most cases of rabies have had some sort of deviation from the recommendations that are out there. So we do have the ability to prevent this. Again, this is such a rare disease. You don't want your claim to fame to be, yeah, the one time I wasn't on top of my game, I caused a case of rabies. It's the last one in the state in 50 years, but I'm the one that caused it. You don't want to be that person. All right, abstract 6, CDC report. Dogs and cats, healthy and available for 10 days of observation. Well, then you can withhold post-exposure prophylaxis until the results are available. If they're not available for observation, call the health department and tell them the circumstances. They'll tell you the prevalence in the area, and you can decide together whether this person should be prophylaxed or not, and document that in the medical record. Immediate treatment is recommended for bites from skunks, raccoons, bats in particular, foxes, woodchucks, and most other carnivores, unless the area is rabies-free. If they know there's no rabies in the area, you don't have to worry about it. Or if you have the animal, if you were angry enough after the bite that you hit it over the head with a shovel or something, and they test it and it's non-rabid, you don't need to go through all those shots. Livestock, rodents, rabbits, very rarely would have rabies and certainly aren't going to be a vector. The only one on that list that's maybe even possible may be rabbit, and that's very, very low suspicion. Almost never require post-exposure prophylaxis. If you see a rabid cow or a rabid bull, just get out of the way. I mean, they're going to gore you before you're ever going to succumb to rabies, so just get out of the way from those guys. All right. What else they noticed here is basically the big thing was meticulous wound care, give the vaccination, give the immunoglobulin within 24 hours. You get a patient that presents after 24 hours, you can make the argument, is it going to hurt to give the immunoglobulin? Maybe it won't, but is there any benefit to really doing it after 24 hours? Not really. And so you have to make the judgment call, and probably you would say, listen, I can start to immunize you, but you're beyond 24 hours, you won't do the immunoglobulin. All right, abstract 7. Recommended approach to evaluation of human rabies exposure in acute care hospital. In 1985, they had one patient that actually had rabies after 10 days in the hospital, and 209 healthcare providers were somehow either minimally or significantly in contact with this patient, and everybody was freaking out. Are you surprised? This is like spinal needle into the back, everybody wants Cipro, right? And that is certainly overkill. We don't need to do that. So do we need to do post-exposure prophylaxis for everyone who's exposed to a case of rabies? Well, what they said was they had these 209 healthcare workers. They talked to the personnel in a meeting and advised them of the low likelihood of exposure. They had them fill out questionnaires about the extent and type of exposure. And then based on those questionnaires, those that appear to be concerning, they did individual interviews. And of those interviews, they said, we're going to recommend post-exposure prophylaxis in 6% of you, and they provided it. Another 18% said, I don't care. I want it anyway. And my feeling with this is we don't know too much about rabies. There's not been too many cases of healthcare exposures to rabies. If somebody wants to spend $2,000 on post-exposure prophylaxis because they're concerned about a disease that's fatal and we don't know much about, why are we worried about that? Let's just do it. And so if someone else said they wanted it, I'm not too concerned about providing it at that point. They said their process really saved the unnecessary use of post-exposure prophylaxis, and they suggested something important here too. If you have a patient you're diagnosing with myelitis or encephalitis, put them in isolation until you've proven it's not rabies. Put rabies in your differential diagnosis. It may be really out there, but if it is and you expose so many patients to a fatal, or so many healthcare providers and other patients to a fatal disease, it could be a problem. All right, what if a person who has already received rabies vaccination has an exposure? So somebody had pre-exposure prophylaxis, they like to hang out in caves, they work at a zoo or whatever. What do you do? Well, what you're going to do is give them a booster, 1 cc at day 0 and day 3, and they should be fine. Don't give RIG, the immunoglobulin, because they're worried about blunting that amnestic response. The amnestic response, basically, we touched on it a little bit with tetanus, is you've already been exposed to the antigen previously. And now you're going to have a more exaggerated response, and you're going to have even a quicker antibody development from this, and that's great. You give the immunoglobulin, and you may likely blunt that response. And so for somebody who's already had a vaccination series, don't give the immunoglobulin. And they also stated, as well in some of the abstracts, that serologic testing to document a response after treatment is unnecessary. Everyone who's immunocompetent is going to respond to this vaccine, so don't worry about it. What you may want to do with patients who have pre-exposure vaccination is occasionally test them serologically to make sure they have seroprotection. And that's reasonable, but we wouldn't do that from the ED anyway. All right, what are the immunization products out there and what do they cost? Well, they are pricey. We know rabies immunoglobulin, we talked about that. It's an IgG product from plasma of hyperimmune human donors. And they go ahead and kill the virus. It's not an issue there. And it gives you passive immunity while you're waiting for that vaccine to kick in for you. So it's a good thing to do if you've never had the immunization series. And it's available as Hyperrab and Imogam. 70 kilogram patient is going to need about 1,400 international units. How much do you think that costs without looking down at your papers? It's $900 per 10 cc's. That's about 9.3 cc's for the 1,400 international units. So one dose of immunoglobulin, $900. And that's not talking about delivery. That's talking about the drug cost itself. So although we want to do this when we need to, we've got to be careful not to do this unnecessarily. Okay, HDCV. This is our vaccination, attenuated strain of the rabies virus from human cell culture. And this is $150 per vial per dose. So $150 per dose. So when we're going to embark on this process again, it is not inexpensive. Abstract number 8, they talked about a new purified virocell vaccine, the PRVR, and it's used in other countries, not FDA approved here, but basically from a clinical standpoint, it's probably equivalent to HDCV, but I don't know the cost on that. So another alternative for us, if it ever gets approved here. All right, abstract number 9, interesting, a case report on neuroparalytic illness and the vaccination. Now this is way back from 1982. It was an 11-year-old that had HDCV. 3 days after the 5th dose, all of a sudden got kind of weird. Had some dysesthesias and leg pain, had trouble walking, muscle weakness on examination, decreased sensation, and an EMG showed peripheral neuropathy. The good news is it was about 12 weeks later there was full recovery with supportive treatment only. That was great news. But the question was, wow, can there be significant reactions from this vaccination? And there can be. But pre-HDCV, it was very concerning. The previous vaccine before that time frame, 1 per 1,600 of those vaccinated would develop this type of complication with a 15% mortality rate. If a dog bites you and that is the risk factor or the risk profile of the vaccination you're going to get, maybe you just want to hang out and see what happens, because it could be pretty significant with a 15% mortality rate. But post-HDCV, very few cases. 2 cases reported, and this was up to 1982. There could have been more since that time. But in 336,000 who had been vaccinated, and none of them were fatal. They were these transient neurologic symptoms that went away with supportive treatment only. So that's speaking to the safety of HDCV. So it's really not an issue for us. It's a safe vaccine and definitely reasonable to give. At the end of this chapter, you'll notice that it was listed New York State Department of Health recommendations. And there are some interesting findings in there. I summarized a couple things for you. If you want to look through the rest at your leisure, certainly do so. But one of the questions they raised is, can people be exposed to rabies and not know it? You know, when do you get concerned when somebody thinks, well, maybe I was exposed? And they really focus on bats. So bats have very small teeth, make very small puncture wounds. You may never even see the puncture wounds, may not even feel the pain. Trust me, if a bat's anywhere near me where they could have bitten me, I'm going to have an idea they were there. But they say that you may not know, so that would be the one issue. Now what's interesting, you take a look at the reasonable probability of exposure based on 5 factors. I think these are interesting and funny. Number 1, contact between a person's bare skin and the bat's head. Well, if the patient doesn't raise the concern at that point, when their bat has been on their skin, that is an issue. Or any part of the bat while not directly looking at the bat. Boy, I tell you, if you were close enough to get a look at that bat and he's looking back at you, get the vaccination right away. A bat found in a room with a sleeping person, that's a bad thing. Bat found in a room with an unattended child, vaccinate the child. And then in some circumstances, a bat found close to an unattended child outdoors, plus or minus. Maybe you want to take a look to see if you see any bite marks. See if, maybe interview the child, see if they flew close to him or something. And then maybe you want to consider vaccination. Bat found in a room with a person under the influence of alcohol or drugs or with other sensory or mental impairment. I think the first step is verify that there was actually a bat. You know, the LSD lady. I mean, ever experienced any bats, flying around when you've had your medications? But, you've got to make sure. If they report this thing was huge, it had a wingspan of 4 feet. All right, this one we don't need to prophylax. You're okay. All right, what should be done? This is the great recommendation from New York that I love. What should be done if a bat is found indoors? It's a one short answer for me: run. That's not what they say here. I love this. And I don't think this has ever been tested. It's never been tested, and I think it'll be painfully clear and obvious why it has not been. They said they want to capture the bat so you can test the bat to see if anyone needs to be prophylaxed. I would go for the vaccination series. Give me double the vaccination series. Inject them anywhere you want as long as I can get out of the room. I mean, I'd be happy to take that alternative. They said to avoid losing the bat, this is the quote, leave one person in the room watching it with doors and windows closed. Doors and windows closed, the bat can't get out and neither can I. That's a bad, bad plan. While another person goes to get a coffee can, lid, gloves, or other similar equipment to capture it. The problem is, and why this has never been tested, is everyone volunteers to get the coffee can. No one stays in the room. Could you imagine this thing flying around? Have you gotten the coffee can yet? I'm still looking. Just get out of the room. Not good. All right. So worry about the bats and bat exposures. The key points and recommendations at the bottom of the chapter. Rabies is a rare but almost always fatal disease, so we have to make sure we're being very vigilant and providing vaccination when it's necessary. Communicate with your local health department for prevalence. Most common animal vectors, bats are the key ones. Raccoons, skunks, fox. Stay away from the skunks anyway. It's got some social implications too. Domestic animals, it's a rare exposure. Rodents don't really function as vectors for this. Post-exposure prophylaxis includes wound care, the immunoglobulin, and also the vaccination. And vaccination costs, I mean, when you go through this whole process, it's somewhere between $1,500 and $2,000. So pick the right cases and provide it when it's necessary, but certainly don't do this when it isn't. It's uncomfortable, and also it costs a lot of money. Although the immunization products are relatively safe, local reactions can happen, and there are some severe systemic reactions that are rare. So again, worry about the side effects, but certainly the benefits almost always outweigh the risks. That's all we have for rabies. If you have any questions, I'd be more than happy to answer them. Yes?
So routine dog and cat bites, the recommendation is call the health department and see what they recommend?
Yeah, he's asking about dog and cat bites, the routine. The first thing is you need to know prevalence in the area. If they tell you we have not had any rabies noted in this area for 15 to 20 years, you're pretty much done at that point. Document the recommendation. Ask them, do you recommend in this particular scenario that we go ahead and either quarantine the animal or that we go ahead and do prophylaxis? They say no. I think you're safe, and you're just safe for the patient and safe medical legally to go ahead and document and not do that. The animal behavior is important though too. If you can't quarantine the animal and it acted really bizarre, well, then maybe you need to take that into consideration and err on the side of conservatism and provide the immunization. The other aspect of this as well is you present the pros and the cons to the patient. If the treatment is reasonable but can go either way, it's the patient's choice, not yours. So if it's reasonable to prophylax because we really don't know for sure, let me lay this out for you and you make the decision as a patient. Yeah?